Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here to explain Kawasaki disease as a link between ophthalmology and rheumatology. Rheumatology is a study of autoimmune conditions, and this has a nature of being systemic. So the autoimmune conditions within rheumatology can attack the eyes as complications or extra-articular manifestations. Some of the diseases, like rheumatoid arthritis, lupus, polymyalgia rheumatica, and psoriatic arthritis, all have well-known ophthalmic complications. And Kawasaki, which is the main topic we will discuss today, is one of the connections between the two fields, as you'll see very soon. So Kawasaki disease is a medium vessel vasculitis with acute self-limited febrile illness, the most common pediatric acquired heart disease in developed countries. The host's genetic predisposition renders vulnerable the microvasculature to any inflammation. The diagnosis is made clinically upon observation of the following 5 signs. To easily remember these, think cream. C is for conjunctivitis in the eyes. R is for rash on the skin. Edema for E. A is for adenopathy in the lymph nodes. And M is for mucosal changes that can be observed on the inside of the mouth or the nose. The anatomy of the anterior segment of the eyes includes the conjunctiva, which is a layer that overlies the sclera. Sclera, as the white parts of the eyes, borders the cornea in the center part of the eyes that bulge out, and this border is called the limbus. Lacrimal duct, located on the medial side of each eye, drains the tears produced from the lacrimal gland. Anterior chamber is a space full of fluid enclosed by the cornea anteriorly and by pupils and iris posteriorly. And speaking of, the pupil is the opening that lets the light into the eyes and eventually lets it become detected by the photoreceptors in the retina. Iris is in charge of controlling the size of the pupil to adjust for light intensity. Pathophysiology of Kawasaki's disease is largely unknown, but it is suspected that abnormal immune response is present to infections or inflammation, and this causes microvasculitis. The population below 5 years of age are at special risk to Kawasaki's disease, and especially Asians and Pacific Islanders are of higher risk than other races. The criteria for Kawasaki's disease is established by the American Heart Association in 2004. To clinically diagnose Kawasaki's disease, the patient must have a fever 5 days or more and 4 or more of the following 5 criteria. 1. Oral cavity and lip changes. So if it's cracked and red lips and the tongue looks like a strawberry and swollen and very red. Polymorphous rash, which is maculopapular in nature, and large areas of redness called erythema multiforme. Third criterion is bilateral conjunctivitis that is non-purulent. Then there must be changes in the extremities, either with erythema or desquamation. Desquamation is D of squamous cells. So a lot of skin peeling, and from the Latin origin, apparently this word means to scrape the scales off a fish. Lastly, cervical lymphadenopathy of 1.5 centimeters diameter or greater is one of the criteria for Kawasaki disease. If the coronary artery is abnormal on TTE, transthoracic echo, the diagnosis may be applied if there's just fever for 5 days or more and 2 to 3 features instead of at least 4. As we've covered already, the symptoms and signs of Kawasaki disease includes fever, greater than or equal to 38 degrees Celsius, and rash, as well as swollen tongue, red and dry lips. Cervical lymphadenopathy, or swelling of the lymph nodes along your neck, especially the sternocleidomastoid chains. This is also an important observation. And in terms of the eyes, bilateral conjunctivitis and anterior uveitis can also occur from Kawasaki disease. In phase 2, there is desquamation at the extremities, joint pain, diarrhea and vomiting, as well as abdominal pain. Complications with Kawasaki disease includes coronary artery aneurysms, valve regurgitations or stenosis, as well as myocardial dysfunction. These are all the lists of the differential diagnosis for someone presenting with the Kawasaki-like syndrome. And this is not exhaustive. There can definitely be a lot of different causes that are similar in presentation. So take some time to pause the video and read through on the list and take a look at some of the pathology pictures, especially of that of the conjunctivitis. For chronic conjunctivitis, that may or may not accompany other symptoms and signs of the Kawasaki's criteria, blepharitis, dacryocystitis, which is inflammation of the lacrimal gland, and nasolacrimal duct obstruction, as shown on the picture on the top right, are possibilities. So always thorough information on how the illness occurred, when they first noticed it, what kind of symptoms and signs did they experience. This is crucial for successful diagnosis and appropriate management. Upon slit lamp exam, evert the lids to look for any foreign bodies and discharges. Look at all the conjunctiva and sclera by asking the patient to look left and right, up and down. Feel free to manipulate the lids as you see fit. Look at the conjunctiva, as well as checking for anterior uveitis. Look for cells and flare in the anterior chamber. Look at the pathologies of the cornea, and observe the iris. Kawasaki is a clinical diagnosis, but some investigations can be done. So cultures and smears of conjunctiva and cornea can be done to rule out any infection. Doing CBCs to check for anemia and look for platelets, as well as white blood cells. Look at inflammatory markers of CRP and ESR to see if they're elevated. Look at the liver enzyme and albumin in the blood. Check the sodium to see if there is adequate fluid in the patient's system. and look at the urine to see if there's pus. Kawasaki disease is treated with pediatric consultation most of the time and hospital admission. IVIG in high dose can reduce the incidence of aneurysms as complications of Kawasaki. Aspirin, which is anti-inflammatory, antipyretic, and antiplatelet, can be given in high dose under circumstances with no fever for 2 straight days, then can be converted to low dose for 4 to 6 weeks. Longer administration of aspirin can be done if coronary dilation or aneurysm is detected. Coronary vessel anomalies can also alter the criteria for diagnosing Kawasaki disease, as we've discussed earlier. Avoid systemic steroids, as it can provide other adverse effects that were not the goals of the treatment. Around 50% of aneurysms regress with treatment and mostly retain the original abnormal vascularity during Kawasaki. If the giant aneurysms are greater than 8 millimeters in length, this is the highest risk for Kawasaki disease. There's an increased risk for thrombosis, stenosis of the vessels, as well as myocardial infarction in pediatric patients. Here are some of the information, the comprehensive summary of everything we've talked about in this presentation. This is the reference that we've used to collect the essential information for Kawasaki disease. And here are references for images. Thank you for watching this video.